Good morning. This is a short video that will be talking about the control of the heartbeats. Um, in this video, we'll be discussing the function of the pacemaker of the heart, the sinoatrial node, as well as another modified cardiac muscle that shares in control of the heart rate. That's called the AV node. So the control of the heartbeats will be through the pacemaker, the original and most important pacemaker of the heart, which is the SA node or the sinoatrial node. And we started discussion of the SA node in class, and then we'll be talking about the atrioventricular node. And then we'll be talking about the heart sounds that we hear during auscultation using the stethoscope. So we'll be talking about the first heart sound, the second heart sound. We'll also be talking about the auscultation areas, meaning that when you use the stethoscopes to listen to the heart sounds of the patients, this is what we call auscultation. When, where, and when are you going to hear certain heart sounds that are related to the closure of the valves. This is the main core of the video, and we will start by the sinoatrial node. As we said in class last time, the sinoatrial node is a specialized cardiac muscle, meaning that it is a part of the myocardium of the heart. It is a part of the cardiac muscle tissue. Myocardium means cardiac muscle tissue. So the SA node is a small area of the myocardium of the heart that lies mostly in the posterior wall of the right atrium. But it's not only about being posterior, but it's also lateral to the side of the right atrial wall and superior. So we can say that the sinoatrial node, which is this part of the heart, is a part of the myocardium. So it is a cardiac muscle, but as it is written on the slide, it is a specialized cardiac muscle. It is located in the right atrium. Where exactly? It is located in the posterolateral wall of the right atrium, meaning that it is posterior, but also to the side, lateral, posterolateral, and mostly towards the superior part of the right atrium. So it is described by being superior or lying superiorly in the right atrium, but posterolateral. All this happens in the right atrium. And we said before that the sinoatrial node is the pacemaker of the heart. What do we mean by the pacemaker of the heart? We mean that it regulates the rate of contraction of the heart. So, pacemaker of the heart means that it regulates the rate of contraction of the heart. If the sinoatrial node beats or sends impulses actually at a rate of 70 beats per minute, then the whole myocardium will beat at 70 beats per minute. And if the sinoatrial node decides to beat at 85 beats per minute, then the whole myocardium will beat at or send impulses to the remaining myocardium and then contract at the rate of 85 beats per minute. So we can say that the pacemaker of the heart means that it is the part of the heart that controls the rate at which the whole myocardium or cardiac muscles will contract. And it forces the rest of the heart to contract at its own inherent rate. Why do we say inherent rate? Because it is a rate that is very specific to the sinoatrial node. It is the power of the sinoatrial node to generate electric impulses spontaneously. So why or which properties allowed the sinoatrial node to be the pacemaker of the heart. There are two main properties that allow the sinoatrial node to be the pacemaker of the heart. First of all, this inherent property of spontaneous generation of electric impulses, meaning that without having received any electric stimulation, it is capable of generating electric impulses on its own and it's in its own rate. So it generates the electric impulses. You can record the electric impulses using a device, and you can see that there is a spike of electricity that arises from the sinoatrial node. We call this spike of electricity, as we'll be learning in the nervous system, depolarization. Or reversal of polarity. We will be studying this in detail. I'll not be explaining this now. But when this wave of depolarization or this electric change spreads over the myocardium, we call this an electric impulse. So generating a wave of depolarization is only one wave. But when this waves, and it is localized in one point, but when it spreads to other areas, it is called an electric impulse or a nervous impulse. So it is capable of spontaneous generation of depolarization, and then of course it will spread to the rest of the myocardium automatically. We will be learning this, we will be learning how this occurs later on to generate an electric impulse. Why is it capable of spontaneous generation of electric impulses? Because of another property, which is instability of the potential membrane, or the potential difference across its cell membrane. Instability of what we call the membrane potential. And I'll be opening a new slide to explain the instability of the membrane potential that allows the sinoatrial node to spontaneously generate electric impulses and to be the pacemaker of the heart. But before opening a new screen and explaining what instability of membrane potential is and how this allows the sinoatrial node to be the pacemaker of the heart, I have to mention a third property other than a spontaneous generation of electric impulses. Actually, the instability of the membrane potential is not a second cause, of being the pacemaker, but actually it is the cause of having the ability of spontaneous generation of electric impulses. And then the second property is that it beats at or generates electric impulses at the fastest rate. So what allows the SNO to be the leader of the heart, to be the pacemaker of the heart, to be the area of the heart that controls the rate of the rest of the heart, is not only having spontaneous generation of electric impulses or having this ability, but also generating impulses at the fastest rate, so that any other area in the heart that tries to be the pacemaker has to beat this record, has to generate impulses at a faster rate. So if we open now a new screen, we will start by summarizing what we have said. So for the SA node that is located in the posterolateral superior wall of the right atrium, it has an unstable membrane potential. It has an unstable membrane potential, and we will be explaining this very soon. And the instability of the membrane potential results in the ability of spontaneous generation of electric impulses, spontaneous generation of electric impulses. And we've just said that an electric impulses is nothing but a wave of depolarization that spreads, a wave of depolarization that spreads over the myocardium is called an electric impulses. But there is another property other than spontaneous generation. It generates at the fastest rate. So no other area in the myocardium can beat the record, and therefore this results in the SA node being the pacemaker of the heart and controlling the pace of the rest of the heart. Another important thing to explain is why is generation of electric impulses important? Generation of electric impulses is important because we have in the body several types of muscles. This type of muscle we are talking about are the myocardial muscles. And the myocardial muscles are involuntary muscles. Actually, under the microscope, they are cylindrical muscles. They are striated just like the skeletal muscles. They have dark bands and light bands, but they are branched, meaning that they are connected. So we can have a muscle cell A that is connected to a muscle cell B, and so on. And this is a major difference between cardiac muscles, myocardial muscles, and the ordinary skeletal muscles that are attached to the limbs. The skeletal muscles usually have tendons and they are attached to bones. But when you see them under the microscope, you will see them cylindrical, banded or striated, but they are non-branched. So this is one important difference between skeletal muscles as we see them under the microscope and myocardial muscles. The myocardial muscles are branched, whereas the skeletal muscles are non-branched. The myocardial muscles are involuntary, meaning that you cannot control their heart rate upon your will, but the skeletal muscles are voluntary because you can give orders to the limb muscles, for example, to the upper limb or the lower limb to contract. This branching between the myocardial muscles is very important because it allows the rapid spread of electric impulses over the surface of the myocardium. And if there is rapid spread of impulses, these electric, and this is very important, these electric impulses will be followed by contraction of the myocardium. And this is an important, extremely important point to understand. No single muscle can contract and shorten where without having received an electric impulse. And that's why in the heart, there should be the pacemaker of the heart, which generates electric impulses. And those electric impulses will spread over the myocardium. And after spreading over the myocardium, they will be followed by contraction. So if the electric impulse starts here, and this is what we will be very soon seeing on the slide, the electric impulse will spread over the atrial muscles first. And then there is here another specialized myocardial muscle called the atrioventricular node present on the upper part, present on the upper part of the interventricular septum or the lower part of the interatrial septum. Because when you are here, then this is the interatrial, this is the interventricular. So you are at the inferior part of the interatrial septum, but at the same time, you are at the upper part of the interventricular septum. The AV node allows transmission of those electric impulses over the myocardium with some delay, and we will understand later on why there is delay. And when it allows this, then the electric impulses spread over both the atria and the ventricle. Every time a single cardiac muscle receives an electric impulse, it will contract. So when you are keen on spreading the electric impulses very rapidly, as we said here, across the myocardium, so you are, in other words, allowing the more or less simultaneous contraction of the myocardium. And when the whole myocardium or all the cardiac muscles contract almost at the same time and simultaneously. This allows a more, I don't say a more powerful only, but a more efficient pumping of blood, a more efficient contraction, and therefore a more efficient pumping of blood to the aorta and therefore to the rest of the body. And now we'll be talking about the instability of the potential, electric potential across the cell membrane of the SA node that allows it to be the pacemaker of the heart. So one of the most important properties that allow the SA node to be the leader is its ability to generate electric impulses on its own. And this, as we said before in the classroom, that makes the heart able to contract even without any extrinsic innervation. It is true that the heart receives electric impulses from outside the heart. So this is the SA node. The SA node is capable of generating electric impulses on its own, and that's why it is the pacemaker of the heart. So if the heart is totally isolated from the human body, it continues contraction if it is soaked in or preserved in a solution that allows its function. But however, inside the human body, there are two nerves that are attached to the sinoatrial node. One of them is the sympathetic, both are involuntary, of course, sympathetic nerve, and the other one is the parasympathetic nerve. These are here just for modulation of the generated heart rate from the SA node. So the sympathetic nervous system stimulates the SA node, increases the rate of contraction from the SA node, and the parasympathetic diminishes or inhibits, not inhibits completely, but diminishes the rate. So if the average rate at rest of the SA node is 70, so increased sympathetic stimulation will make the rate 80 beats per minute, and increased parasympathetic stimulation will make the rate 60 beats per minute. This is a normal physiological adaptation, meaning that the sympathetic nervous system, as we said before, acts whenever there is a fright, for example, fear, fight, or flight. You're fighting, you're on a plane, and you are worried about the safety in the plane, or you're scared for a reason or another, then the sympathetic nervous system is taking over, has the upper hand, and this is normal because whenever you are in a dangerous situation or whenever your body thinks you are in a dangerous situation, then the pulse has to be increased, the blood pressure has to be increased to provide more blood to the muscles that might be used in fighting, in jumping, in escaping, and more blood to the brain to allow you to think and to make plans to escape this assumed or alleged risky condition. On the other hand, the parasympathetic system occurs during rest, or is predominating during rest, during sleep, during digestion of food, when you're eating, when you're relaxed, when you're sleeping. And that's why the basal heart rate when you're sleeping is around 60 beats per minute if your heart is functioning normally. So although the SA node is capable of generating electric impulses on its own, and although it does this every fraction of a second, yet there is what we call extrinsic innervation in the form of the sympathetic nervous system and the parasympathetic, and the sympathetic and parasympathetic nervous system are both belonging to what we call the autonomic nervous system, because your nervous system is divided into voluntary nervous system and autonomic or involuntary nervous system. The voluntary nervous system is what allows you, for example, to give orders to the skeletal muscles of your limbs to contract and move on purpose. And there are many numerous examples, but the involuntary nervous system is responsible for all what you cannot control. And the involuntary nervous system is divided into sympathetic, which is the stimulatory one, and parasympathetic, which is the inhibitory one. So, for example, you cannot control your heart rate. You cannot control peristalsis in the small intestine. You cannot control your pupil in the eye to dilate or constrict. All this is under control of the autonomic nervous system. The last thing to say is what is instability of the membrane potential. Every cell in the human body has a cell membrane, including the myocyte or the myofiber or the cardiac muscle fiber. So this cell membrane has encloses inside the cytosol and is present in extracellular fluid. However, this extracellular fluid is minimal. So you have intracellular fluid, the fluid part of the cytosol, and extracellular fluid. And usually there are ions that enter and leave, like sodium, like potassium, and so on. They're all the time entering and leaving the cell according to certain rules, and either when they are ions, of course, and charged, they cannot pass directly through the cell membrane. They have channels, protein channels, that allow them to enter and leave. Whatever the ion that is moving inward or outward, there are common rules. The main ion intracellularly is potassium, and the main ion extracellularly is sodium. And we always try to keep this. The homeostatic mechanisms in the body keep this. So sodium is the main ion extracellularly, as you know from grade 10, and potassium is the main ion intracellularly. But this doesn't mean that there are potassium ions outside, but in lower concentrations. And this doesn't mean that there aren't sodium ions inside, but in lower concentrations than potassium. And this doesn't mean that there aren't negative ions like chloride ions inside and outside. So the presence of these ions creates a certain potential difference. Potential difference means what? For example, in electricity, if you're talking about a battery, for example, if you're talking about the positive pole of the battery and the negative pole of the battery, the current always passes from where you have excess electrons to where you have fewer electrons. But conventionally, scientists have admitted that the current will be said to pass from the positive to the negative. But whatever the definition is, there is flow of electrons. And this flow of electrons is due to the presence of a potential difference between the two poles of the battery, meaning that there is an area with more electrons that passes to the lower electrons area. This is rather similar to osmosis, to diffusion. You have more electrons on one side, so they move to the other side until equalization. So this is what we call potential difference. When this potential difference is present across the cell membrane, we call it a membrane potential. Membrane potential. And if the cell is not stimulated by an electric impulses, then we call it a resting membrane potential. And in the cells, the resting membrane potential is due to the difference in ion concentration across the cell membrane. Ion concentration, positive and negative ions. And usually we have the outside of the membrane positive in relation to the inside. So this is the the resting membrane potential, meaning that you have the inside of the membrane negative in relation to the outside, and the potential difference is 70 millivolt. and we say minus 70 millivolt, just to indicate that the inside of the cell is negative in relation to the outside. This is the value, the absolute value of the resting membrane potential. What does this mean? This means that the algebraic sum inside is negative and the algebraic sum outside is positive, meaning that inside the cell membrane, or on the inside of the cell membrane, we have positive and negative charge, but the negative is more. And outside, we have still negative and positive charge, but the positive is more. And then when there is an electric impulses that reaches the myocardium or the muscle cell, what happens is a reversal. So we have here the resting membrane potential, and in the resting membrane potential, the outside of the membrane is positive in relation to the inside. But when an electric impulses reaches, or a wave of depolarization reaches it, the opposite occurs. So the outside of the membrane becomes negative in relation to the inside. Why does this happen? This is a bit complicated, or this is not the proper time to explain this, but simply speaking, this happens because of opening of channels and entry of sodium ions and potassium ions going outward. So there is a movement of ions, and the overall or the net result is the occurrence of this reversal of polarity. Why do we call it reversal of polarity? Because the inside is now becoming positive after it was negative, and the outside is becoming negative after it was positive, and that's why we call it a reversal of polarity or depolarization. And this is the source of the spike of electricity that we see on the tracing and that we call depolarization, meaning that after having the electric potential being equal to minus 70 millivolt, it is now positive, for example, plus 30 millivolt. And if this wave of depolarization spreads to the remaining areas, then we call it an electric impulse, as we said before. So we talked about the control of the heartbeats and how there is a wave of contraction because the cardiac muscles are stimulated in series, and when they are stimulated, they respond by contracting, and this ionic change that occurred will be spread to the neighboring cells, and the neighboring cells will contract. And we said that the spread is very rapid because it is related to the branching of the cardiac muscles, and this occurs in a rhythmic, regular way, as we said, that ranges between 60 to 90 beats per minute. When this occurs, when the pulse rate originates from the sinoatrial node and is regular and occurs within the rate of the sinoatrial node, which is 60 to 90 beats per minute, we call it a normal sinus rhythm. So what is a normal sinus rhythm? It is the heart rate that originates from the normal pacemaker, which is the sinoatrial node, that is regular and that occurs at the rate of 60 beats per minute. On the other hand, we have the atrioventricular node. As we said before, the atrioventricular node is another specialized part of the myocardium that lies here. When the electric impulses reach from the atria to the ventricles, they must pass through the atrioventricular node and then through the interventricular septum to spread to the myocardium. So the first function of the atrioventricular node is transmission of the electric impulses from the atria to the ventricles, but at the same time, the AV node has the ability to generate electric impulses but it is slower than the sinoatrial node. That's why it's not the pacemaker. But if the pacemaker is sick, if the SA node for a reason or another stops working, is diseased for a reason or another, maybe because of a medication, maybe because of ischemia or blood not reaching it sufficiently, then the AV node will be the pacemaker of the heart. So you can consider the AV node as a reserve pacemaker of the heart, or the deputy of the SA node. In case the SA node becomes sick, the AV node takes the upper hand. But why, under normal conditions, isn't the AV node the pacemaker? Because the rate of the SA node is slower. The SA node generates the SA node generates electric impulses at a rate of 40 to 60 beats per minute, which is much slower than that of the SA node, which is 60 to 90 beats per minute. So the AV node is a spare pacemaker. The AV node is a spare pacemaker. So as the slide shows you, we are going to summarize the functions of the AV node. First of all, location, it's located in the upper part of the interventricular septum, or you can say in the lower part of the interatrial septum. So it receives and transmits, but when it transmits the electric impulses, it transmits them with delays. Relay means transmit. So first of all, it receives the electric impulses from the SA node, and then it relays the electric impulses from the atria to the ventricle, and relays means that it conducts, the more specific word is, more specific than transmit is conduct. It conducts the electric impulses, and it conducts with a delay, so it slows down the conduction. Why is this delay important? It is important for two reasons, but notice that this delay is what prevented the AV node from the privilege of being the leader or the pacemaker of the heart. The first thing is that this delay is very important, because if we know that the conduction across the myocardium is very rapid because of the branching and because of other structures that we'll be mentioning later on. But imagine that the electric impulses passed very rapidly in no time from the atria, while they are still in their systole, to the ventricles. Of course, once the ventricles receive electric impulses, they will contract and they will start their systole. So it would be catastrophic, because the systole of the atrium will occur at the same time as the systole of the ventricle, and the blood flows will antagonize each other. It's true that the ventricles are more powerful, but this would greatly diminish the efficiency of ventricular contraction. So first of all, it prevents simultaneous contraction of the atria and ventricles. The second important reason is that delay simply means that we are delaying ventricular systole. And if we are delaying ventricular systole, then we are keeping the ventricles for a while in diastole. And if we are keeping them in diastole, relaxed, then we are allowing them to stay dilated, not contracted, having a cavity with a larger volume. So we would have a larger cavity, and that larger cavity will allow more time for filling with blood. Why do we want to give the ventricles enough time to fill with blood? Because when they fill with blood, when they fill adequately with blood, then they will later on carry out adequate pumping of blood. So if you want the ventricles to contract and efficiently pump blood into the aorta or into the pulmonary artery, you have to give them time to relax. As we said before, the cardiac cycle in general consists of contractions and relaxations. The cardiac cycle means what? A cardiac cycle is the regular repeated events in a very regular manner that occur. If the heartbeat is the heart is beating at the rate of 70 beats per minute, then the cardiac cycle would be the regular repeated events that occur 70 times or that are repeated 70 times a minute. Usually, we divide the cardiac cycle into two phases. And the phases are mainly based on the ventricles, as we said before in the class, because the ventricular muscles are predominating. So systole is when the ventricles are contracting. So we define the cardiac cycle by two phases, and we are focusing on, in our description of these phases on the ventricles. So systole is the phase when the ventricles contract, and diastole is the phase when the ventricles relax. Afterward, we can know in detail what happens to the atria during ventricular systole and what happens to the atria during ventricular diastole, but for the time being, we are focusing on the ventricles. And of course, as you all know, when the ventricles are in systole, when they are contracting, the atrioventricular valves should close to prevent backflow, and the semilunar valves should open. Because why are the ventricles in systole? Why are the ventricles contracting? Because they want to push this blood into the aorta from the left ventricle and into the pulmonary artery from the right ventricle posteriorly. On the other hand, when the ventricles relax, they relax to allow the atria to pass blood to them. So the atrioventricular valves should open. But when they relax, there is fear of regurgitation of blood from the large arteries like the aorta and the pulmonary arteries, as we said before, and that's why the semilunar valves should close. When you use your stethoscope, like all medical doctors do, you use the stethoscope to listen to this is the stethoscope. It's like a well-conducting rubber tube with a piece of metal here, and that piece of metal has a very thin membrane or diaphragm. You put it on the chest wall. You will be doing this in the lab at school, or the lab is the title, but this will be done in the classroom to listen to the heartbeats using the stethoscope. You hear lub-dub, lub-dub, lub-dub. These are the heart beats. And why are we saying lub-dub, lub-dub? This is how the first medical doctors that listened to the heart using a stethoscope or even using their ears heard the heart. So every heartbeat has its own lub sound and its own dub sound. Why is it split or differentiated into two sounds? Because the first is called the first heart sound, the second is called the second heart sound, and it is related to the closure. So actually, the first heart sound is heard when the atrioventricular valves close, and the atrioventricular valves close at the beginning of systole. And you have to say beginning. The second heart sound, dub, is heard when the semilunar valves close. So it's always about closure, and it's always about closure of valves. But the S1 is due to closure of the atrioventricular, and the S2 is due to closure of the semilunar valves. And the semilunar valves, on the other hand, close at the beginning of diastole. And I'll be sending audios to you to listen to the normal heart sound. But sometimes when the valve is not competent, when there is regurgitation, some blood will flow backward, as you know. So you will hear an abnormal sound superimposed on lambda. For example, if there is aortic incompetence, then at the beginning of diastole, you will hear the first heart sound, and then you will hear the second heart sound, and then you will hear an additional sound superimposed on S1 and S2, which we call the murmur. And every time you hear lub dub, and then you hear a blowing sound, and the sound differs according to the murmur, and the murmur differs according to the valve and to the type of damage in the valve. So what is a murmur? It is an additional abnormal sound that is superimposed on the normal S1 and S2 sound. Similarly, if the valve is narrow and stenotic and the blood finds resistance during passage, you will hear a murmur due to stenosis. In all cases, we will be studying this in detail, of course. We'll be listening to them, but we have to know that in general, a murmur is an abnormal heart sound superimposed on the normal S1 and S2 sounds. This is an audiogram. This is a tracing or a tracing that records the normal heart sound. Of course, here you have the first heart sound, you have the second heart sound. This is the time in seconds. And this is a normal audiogram. Why is it a normal audiogram? Because there are no murmurs at all that are superimposed on of course, the y-axis represents the intensity of the sound. In here, S1 is due to closure of the atrioventricular valves, and we said that this occurs at the beginning of systole. Here, this is due to closure of the semi-lunar valves that occurs at the beginning of diastole. So if this is the beginning of systole and this is the beginning of diastole, which is the end of systole, then this duration is the systole. And on the other hand, this duration will be the diastole. So systole, diastole. And you can notice that diastole has a longer duration than systole. And this means that the ventricles remain in relaxation for a longer period than when they are in contraction or systole, to allow more time to fill with blood, but also to allow more time to rest in order to prevent fatigue. We said before that the cardiac muscles are rarely fatigued, partly because they have a lot of mitochondria that generate energy, but also because they are allowed to relax for a longer period of time. The last slide I'll be discussing, and I apologize for the extra few minutes. Where are we going to put our stethoscope? This is what we call the auscultation areas. There are certain areas where you can best hear a certain sound. So we have how many valves? We have four main valves. We have between the right atrium and the right ventricle, we have the tricuspid valve. We have here the bicuspid valve or the mitral valve. And then we have the aortic valve. And at the beginning of the pulmonary artery, we have the pulmonary valve. So at least you should know four areas, but you have to locate them. These are the clavicles. This is the manubrium sterni. This is the body of the sternum, and this is the sternal angle. If you look carefully, you will find that this is the first rib, second rib. So the space in between the first rib and the second rib is the first intercostal space. The sternal angle is opposite to the second rib, just above the second intercostal space. So what you do when you want to listen to the heart sounds using the stethoscope, because we are talking about auscultation, so you are using the stethoscope, you scroll your index finger from the this is what we call the sternal notch, and this is what we call the sternal angle. So you start by the sternal notch and you move downward from the sternal notch to the sternal angle, and then you go laterally to the right and to the left to make sure that your index finger is touching the sternal angle, the bump of the sternal angle. You will find a bump here, and then in front of it, you will be sure that you are in front, you're now sure that you are in front of the second rib. So you go to the right, you touch the second rib, and you descend. When you descend, you are in the second intercostal space. The second intercostal space is this one, and it is the space between the second rib and the third rib. On both sides, the second intercostal space is very important. Why? Because it is the auscultation area for the aortic valve, which we call the aortic area. And on the left side, it is the auscultation area for the pulmonary valve. Notice that they look as if they were exchanged. Why is the aorta to the right? Because at the beginning, when it arises from the left ventricle, it is inclined a bit to the right, the ascending aorta, before turning to form the arch. And the opposite occurs for the pulmonary artery. So the aorta is moving like this before arching, and the pulmonary artery is moving like this. So the aorta is moving to the right side and then arching, whereas the pulmonary artery is moving to the left side. So you will be hearing you will be best hearing. I'm talking about best hearing. It's true that you can hear the aortic sound, or all the sounds arising from the aorta from neighboring areas, but the best place is the aortic area. How can we describe the aortic area? It is the second right intercostal space at the sternal border. The pulmonary area, it is the second left intercostal space, just to the left of the sternum. And then we have the tricuspid area, which is in the fifth intercostal space, left intercostal space, and the mitral area, which is exactly the area of the apex, which is the fifth intercostal space at the mid-clavicular line. You can ignore Erb's point for the moment being. And having done this, I can say that we have finished what we should have covered on Thursday. Thank you so much, and you will be receiving your classwork sheet very soon on Google Classroom.